Dr. Ragle here from Vet Triage. We are on the very last article here from JAVMA 2014. We are talking about the use of a motorized morcellator for elective bilateral laparoscopic ovariectomy in standing equids. 30 cases, 2007 to 2013. This is a picture of standing surgery, how they would do it. So in large animals, they would give local anesthesia at certain points, which would numb the nerves leaving the spinal cord, and those spinal nerves becoming peripheral nerves would then numb the area that you're going to perform your surgery. And so this is them prepping the horse for the injections and giving the injections here. And so that's what we're talking about when they say here standing equids, meaning that the horses are standing during the surgery. Laparoscopic obviously uses laparoscopy to perform the procedure. Ovariectomy is removal of the ovaries. And then this is a picture of the motorized morcellator. It's a laparoscopic tool that's used to grab a piece of tissue that you're planning on removing from the body, and instead of making your incision bigger so that this piece of tissue can fit, you are morcellizing it so that it becomes this like goopy stuff that then you can remove from the body. Study comes out of the veterinary school in Washington State University. I've actually given a talk there as well. The objective of this paper is to describe the use of a motorized morcellator for elective bilateral laparoscopic ovariectomy in standing equids and to evaluate long-term outcome. Retrospective study, 30 horses. 30 is not a bad number. You always want more, but that's not too bad. It is retrospective, so it's going to be subject to inconsistencies with medical record taking. Results found the median surgery time was 102 minutes. Median single ovary morcellation time was 3.5 minutes. The intraoperative complications occurred in 2 out of 30 cases. One was iatrogenic organ damage of the uterus. Iatrogenic means caused by the medical staff. And the second was persistent hemorrhage. 19 of 20 mares for which long-term follow-up was available returned to their previous use at a median of 60 days after surgery, ranging from 21 to 180 days. Again, the problem with retrospective studies is that they're not standardized, and also I wish they would just use percentages instead of absolute numbers. Conclusions and clinical relevance. Results of the present study indicated that use of a mechanical morcellator with a 2-portal technique for bilateral laparoscopic ovariectomy in clinically normal horses eliminated the need for a large laparotomy incision as well as a 3rd portal. Those would be your options. If you do not use a morcellator, you'd have to either make a larger incision or use another portal. Introduction. Unilateral ovariectomy is most commonly performed for treatment of ovarian cancer. Bilateral ovariectomy is an elective procedure for behavioral modification or estrus behavior suppression or sterilization for registration or preparation for jump mares for collecting semen, and also you would use a surgery for eliminating chronic visceral pain occurring during estrus. Historically, ovariectomy in mares has been performed via colpotomy or ciliotomy or laparotomy. Serious complications are reported and include exsanguination, shock, adhesion formation, abdominal pain, peritonitis, dehiscence, and evisceration. Laparoscopic ovariectomy was first reported in the 1990s. The use of laparoscopy has reduced the morbidity and mortality rates historically associated with ovariectomy. Advantages of scoping in standing mares include direct visualization of less accessible abdominal viscera, the ability for local anesthesia to be delivered in adequate volume under direct observation, tension-free manipulation of ovaries, and smaller flank incisions. The advent of feedback-controlled bipolar vessel sealing instruments has further simplified ovarian dissection and hemostasis. After transection, the extraction of normal ovaries from the abdominal cavity requires conversion of a laparoscopic portal incision to a 5 to 8 centimeter paralumbar laparotomy. Larger paralumbar incisions have been associated with increased complication rates as incision size increases. Incision site defects and hernias can also remain visible. Mechanized morcellators have conical blades designed to core, peel, and cut masses for piecemeal extraction, thus avoiding large incisions for tissue extraction. In human surgery, the first mechanized morcellator was used in a study for extraction of masses from the abdomen in obstetrics and gynecology. So I'm not sure if the morcellator allows you to biopsy a tissue you're removing. It makes sense for ovariectomies if you're performing it for prophylactic reasons. There's no need to biopsy the ovarian tissue. But if you're removing cancer from the abdomen, I wonder if the morcellator messes up the ability for the pathologist to evaluate those tissues histologically. Here is a drawing of their approaches where they're going to place the ports, right there. And so in the pictures is a two-portal technique for bilateral laparoscopic ovariectomy with a mechanical morcellator. In the picture labeled A on the left side, the portals were located between the 17th and 18th ribs at the ventral aspect of the tubercocci, which is portal L1, and then on the mid-paralumbar fossa, 3 to 5 centimeters below the level of the ventral prominence of the tubercocci, portal L2. On the right side, in section B, portals are located between the 17th and 18th ribs at the level of the ventral aspect of the tubercocci, portal RA, and on the mid-paralumbar fossa at a level 3 to 5 centimeters below the ventral aspect of the tubercocci, which is portal R2. Materials and methods. They used penicillin G potassium, gentamicin sulfate, phenbutylzone, or flunixine meglumine, and then detomidine hydrochloride. Standing sedation was maintained by means of intravenous infusion of detomidine hydrochloride. 15 to 30 mLs of 2% mepivacaine hydrochloride was infiltrated at each site. And then a close-up of the motorized morcellator there. That's the instrument they're going to use. I don't know why it's in black and white. I mean, why can't you just put this stuff in color, man? Photograph of the morcellator with grasping forceps inserted into the barrel. After surgery, penicillin G potassium, gentamicin sulfate, and NSAID, either phenylbutazone or flunixin meglumine. Results. Median age was 9.2 years. Most were quarter horses, then molly mules. The reason for surgery is prevention of behavioral signs of estrus, or because of aggressive behavior, or because of training behavioral issues. And then the drawings here, these drawings, the mechanical morcellator for ovariectomy in standing equids in picture A. There's a grasping forceps placed through the barrel of the morcellator to grasp the ovary. And then in picture B, the ovary is being drawn into the morcellator barrel and is making initial contact with a conical blade. And then in picture C, the ovary is being further withdrawn into the morcellator barrel. Notice the peeling action of the blade has created a singular piece of tubular tissue, and the proper ligament is about to be transected. So that's what we're talking about here. They're going to transect the proper ligament to complete the procedure. Complications consisted of iatrogenic organ uterus damage and persistent hemorrhage. Mean surgery time from portal incision to skin closure was 104 minutes. Morcellation time, based on video review, was a median of 3 minutes and 30 seconds. Post-op complications, 3 of 30 patients had elevated rectal temperatures. Median follow-up time was 314 days. 19 of 20 owners perceived the surgery to be effective. Median time to return to activity was 60 days. 18 of 20 patients were returned to their usual activity. Discussion. Advantages of the technique include elimination of the need for general anesthesia. You can also have consistent observation of dorsal abdominal structures, tension-free tissue manipulation, excellent hemostasis, reduction in number of portals from 3 to 2, and elimination for the need of a larger laparotomy for extraction of the ovary. Laparoscopic ovariectomy techniques in recumbent or standing horses were initially described in the 1990s. The modifications adapted have included dissection and ligature placement, endoscopic technique, laser dissection, staples or clips, endoscopic stapler and pouches, emasculators, electrocoagulation, polyamide tie wraps, ultrasonic shears, harmonic scalpel, and vessel sealing device. The morcellator barrel, 13 to 15 millimeters in diameter, does not require enlargement of the original portal incisions to introduce it into the abdomen. The surgeries were completed with 2 portals per side, decreasing the number of incisions, which further decreases the invasiveness of the procedure. It is not routine to use abdominal insufflation unless visibility is poor. This is facilitated by the dietary preparation before surgery and results in reliable visualization of the dorsal abdominal structures in most patients without abdominal insufflation. This further reduces the equipment necessary for the procedure. And abdominal insufflation, which is placing carbon dioxide into the abdomen has its own potential risks and complications associated with it. In human medicine, reported complications of morsellization of cancer are development of parasitic masses at the surgery site, within portal tracts, and on the visceral surfaces, with at least 3 human deaths attributed to the use of morcellators during laparoscopy in another study. The exposed morcellator blade and barrel must be within the visual field at all times. Other important considerations include maintaining adequate space between the morcellator and surrounding viscera, and patient sedation and restraint. Median surgery time was 102 minutes. Regardless of previously used methods of transection, exteriorization of the ovary requires an enlarged flank or vaginal incision. Paralumbar fossae incisions have been reported to be predisposed to infection and prone to incisional problems, despite long morcellations and operation times of between 2 and 4.5 hours on large neoplastic ovaries. No incisional complications were reported in 7 mares in a previous study. So overall pretty standard retrospective study. Obviously you want them prospective and more animals, but not too bad. We are done with this issue of JAVMA, and tomorrow we'll begin the next issue here. Thanks for supporting the channel. We'll see you in the next one. Bye-bye.